as you know, the last 2 years, we in public, 3 years now, we in public health have had just a little thing keeping us busy. And obviously this will come in to that, and we'll try to be careful not to make this a COVID clinic, because obviously there'll be life beyond that. But in truth and in fact, I tell people, the last pandemic before COVID was the 2016, 2018 flu, the so-called Spanish flu, 100 years before, 100 years ago. The last pandemic before that was the Black Death, 600 years before that. So we're getting from 600 years to 100 years, and more than likely the next pandemic is probably within the next 25 years, because the factors that led to COVID, are still there. Global warming, the interconnectivity of the world. I give the example, as an immigrant 100 years ago, my ancestors go into the bush to catch bushmeat. It took them 3 days to get there, 3 days to get out. They'd get some disease. In those 3 days, they couldn't make it out, and they couldn't spread it beyond the village. Now they have a little Chinese motorbike. They're 30 minutes into the bush. They get the disease. 30 minutes later, they're back in. I am there on holiday. I pick it up, and 24 hours later, I'm talking to you. And then agriculture. We are breeding animals in a commercial rate and living next to them in the ways we've never done before, and it's going to continue like that. So the next pandemic is around the corner, and what COVID has taught us is the public health response that we ordinarily prepared, which is FEP, which we developed after September 11th. It is very downstream. It's very post-event, an event. A terrorist has released a biological agent. How do we get the countermeasure out to the community? That response, where it has its use, but it was limited during COVID. The things we need to do are more social determinants, are more upstream, and kind of, find vulnerable populations and really deal with them ahead of time. Now, the FEP funds do some of that, but again, it's very identify the vulnerable populations and try and get the countermeasures to them, rather than a lot of with COVID where we're doing testing and vaccines, and it's a bit more upstream, and then the vulnerable populations weren't necessarily the historically vulnerable populations we think of, right? Immigrant workers in a chicken farm, or in a chicken plant. I mean, those are vulnerable populations, as we saw. So again, identifying community health workers who have Spanish-speaking skills, who have certain other skills. And thankfully, the feds, with your help, have given us a lot of funds for that. But the funds, unlike FEP, are going to end at some point. So, if there is a way, and I was talking to Nick about it, of us beginning to think about public health and the future and the next crisis, which again is around the corner. And beginning to have a long-term plan for a public health response, similar to what we've done with the countermeasures post 9/11.
Some of what you're talking about is a very clear way for us to contend with, be it a pandemic or challenges that people who may not be people with chronic diabetes, with diseases that can be manageable, but without engaged and consistent medical care can become really highly problematic. And so some of the ways from what, either be it mobile health unit or the way to deliver care into communities, whether it's setting up an infrastructure so that in a worst case scenario in the future you're prepared for it, that's one element of it, but the reality is in the here and now, you can also provide the care that's necessary to, keep people from calling first responders because they're in an absolute moment of crisis because they weren't getting the ongoing care they needed for a health condition or a heart condition or diabetes or